All right, it's 4 o'clock. So why don't we get going? All right, hi everyone. Welcome to another edition of Tumor Talk. Today we are really having a special show, I guess, or a special webinar. It's rare that I have ever, promoted work that I've been involved with, but we are pleased to have Dr. Justin Silverstein with us, and Dr. Silverstein does all the neuromonitoring here at Lennox for the most part. And, in the short time that I've known him, we've worked together a lot, and I think he's just a very unique mind from a neuromonitoring perspective. And this is a paper that we published out of Lenox Hill using data both before I got here and since I've been here, discussing kind of neuromonitoring in brain tumor patients and how we should interpret motor evoked potential specifically. And so, Justin, welcome. I really, happy that you're here and able to talk with us. Why don't you give us a little introduction to yourself, your kind of, how you got involved in neuromonitoring, and then take us right in.
Great, thank you, Dr. Mugo, Jan. So, I'm a clinical neurophysiologist. Obtained my doctorate from ATC University in Arizona. I've been doing this for over 20 years, and I'm very heavily involved in research in surgical neurophysiology, and we'd like to share, some of our data that we recently published in the Journal of Neuro-Oncology here, specifically, like you said, talking about motor evoked potentials and motor evoked potentials. Just to kind of give a brief overview, very brief overview, was first applied in awake patients for direct cortical stimulation, and it's one of the oldest modalities that we still use today. They were doing it, with battery-powered bipolar probes in the late 1800s, stimulating primate brains to see gross motor movements. But it was really Penfield and Baldry in the 1930s who made a standard practice when they started stimulating awake patients, and figured out that topography of the brain, somatic topography of the brain, and really figured out where motor and speech were by stimulating awake patients. And they used a long train method, what we call the Penfield method now, where they were stimulating the brain with a bipolar probe for 4 to 5 seconds at a very low frequency, 60 hertz here in the United States, 50 hertz in Europe. And this was how motors were pretty much done. You would stimulate and watch the patient physically move or twitch. But it wasn't until the 1990s where Taniguchi developed an ability to elicit a motor evoked potential, where it was time locked, where we stimulated and saw a response on an oscilloscope. We saw it on a screen in anesthetized patients. That was really the hardest part, was getting motor potentials to be accomplished in patients that were under general anesthesia. And the way they did that was by applying short train, high frequency, multi-pulse stimulation. We do this direct cortically when we place a strip or a grid on the brain directly. And when we do this, it's less risk of inducing a seizure than the long train. You're not stimulating for 5 seconds, you're stimulating for less than a millisecond. And there's no patient movement. We're looking at a response recorded from electrodes placed in a muscle. So it's a very kind of microscopic response compared to those gross movements that you see when doing the Penfield method. And what's nice about these types of motors that you can do them continuously throughout a procedure. So while the surgeon's doing the procedure, we can have real-time feedback on how that motor system's working, functioning. And should there be an adverse event to the motor system, we can intervene immediately as well. And the stimulation for direct cortical motors is very superficial. So we're able to target structures that are at risk and monitor structures that are at risk, whether it's the primary motor cortex or the cortical spinal tract with the brain. In the early 2000s, we were able to take the application of multi-pulse stimulation and apply it transcranially by putting electrodes over the scalp. Now, this causes a lot of movement because we have to penetrate electrically through the scalp, through the cranium, and we need a much higher intensity of stimulation. So because of that, this does cause movement. And in brain surgery, we use transcranial motors kind of redundant to and complementary to direct cortical motors when we can do direct cortical motors, or we use it as a pilot to see, are we going to get uh, any type of motor potential from a patient that's under anesthesia that may have a pre-existing weakness. So what motor potentials do is they provide a structure function relationship, and we target multiple muscles contralateral to where the surgeon's working. And what you see here is that time locked, these little blips on the screen here are time locked responses. That's basically motor function of a patient in the upper extremity and lower extremity, transcranially and direct cortically, and what it looks like on essentially an oscilloscope on a computer screen. And the idea is that in order to get this response, we need that multi-pulse stimulation, which is what kind of show here in the schematic. And what we're doing here is priming the anterior horn of the spinal cord here to basically prime the synapse between the upper motor neuron and the lower motor neuron in order to get that time lock response on a screen that essentially looks like this. So that's where multi-pulse stimulation is very useful and needed in anesthetized patients. One of the things that we do have to look at when we're talking about transcranial motors, because we can't always do direct cortical motors. Again, direct cortical motors is replacing a strip or grid on the brain directly. Sometimes we can't get a strip or grid on the brain, whether it's because there's scar tissue or brain is swollen and it's not safe, or there's just resistance putting that strip in, and we don't want to hit a bridging vein. So we have to rely strictly on transcranial motors. Now, the thing about transcranial motors is that we are stimulating at a much higher intensity. And just to kind of give you an example, we typically stimulate at about 15 milliamps for direct cortical motors. We stimulate between 2 and 500 volts for transcranial motors. So what we have to do is try to make our stimulation as focal and as superficial as possible. So we try to control the best that we can for what's known as the crossover, the coactivation response. And basically what this is if we look at, this is a left upper and lower extremity motor response, and this is an ipsilateral right-handed response. We try to not have this come in, because if this is coming in, it means we're most likely bypassing structures that we're concerned about in the brain. We're activating deeper structures, whether it's in the basal ganglia, down in the brain stem. It's just too deep. We might, if we're working more superficially, we may miss something if we had this response. We do the best that we can to get rid of this response here. Now, that being said, just because we don't have this response, we really don't know how deep we're penetrating with our stimulation. So that's where the direct cortical motor and the transcranial motor act as complementary to one another, because if we lose one, we lose a direct cortical motor during surgery, and we also lose the transcranial motor, we know something's happening to the cortical spinal tract. If we lose the direct cortical motor and not the transcranial motor, well, it might be because something's happening to the cortical spinal tract, but we're not seeing it because we're penetrating too deeply with the direct transcranial motor. So we decided to start looking at whether or not motor potentials can prognosticate short and long-term motor function of brain tumor surgery. So what we did was we evaluated 121 patients who underwent craniotomy for tumor resection at our institution. And the most common types of tumors that we saw were glioblastoma multiforme, metastases, and then meningiomas. 81 patients had both transcranial motor potentials and direct cortical motor potential monitoring. 34 patients only had transcranial motor potential monitoring. And again, that's likely because we couldn't place a strip electrode. Either it was a revision, or there was scar tissue, or the brain was herniating, it was just too swollen, or there was resistance placing the strip, because the strip has to go, especially if you're not directly doing a case, you're not doing a surgery in the motor cortex directly, and the motor cortex is further away. We have to slide that strip electrode towards the motor cortex. And if there's any resistance, we don't place that strip electrode. We don't want to hurt the patient by any means by placing an electrode. And then 6 patients had awake surgery where we only do direct cortical motor monitoring. We won't do transcranial motors in a patient that's awake because they're moving. It'll cause them to move too much. We can't control their jaw. We stimulate them transcranially, and they could bite on their tongue. And if they're awake, they're usually talking to us, so we can't put safety measures in their mouth, what we call bite blocks, to ensure they don't bite their tongue. So we don't do transcranial motor monitoring at all, make surgery, only direct cortical, because there is no patient movement. The patients don't feel it when we stimulate them at all in these cases. So we categorize our motor recordings by whether they were stable throughout the procedure, meaning we had a good baseline, and at the end of the procedure, they were still there, temporarily, partially, or completely lost, but returned prior to the end of procedure with intervention, or permanently fell below alert threshold and at least one extremity and did not recover with intervention prior to closure. We considered a true positive alert to have occurred if they fell into category 3 and the patient will new motor deficit, and a true negative if they fell into categories 1 and 2 and the patient will intact. And we considered false negatives if the motors fell into categories 1 or 2 and the patient had a postoperative motor deficit, and a false positive if the MEPs fell into category 3 and the patient awoke intact. So what we found was that 42 of 121 patients had immediate postoperative motor deficits. 25 patients had full motor recovery at discharge, whereas 17 had persistent deficits. And then at a 3 to 6 month follow-up, 25 patients were lost to follow-up or succumbed to disease progression. And then 34 patients had disease progression and were excluded. And this is one of the things that this specific paper looked at and accounted for, was taking into account disease progression and whether or not we were able to follow that. This is also one of the largest cohorts that's been published to date, specifically for brain tumor surgery. And we did have one patient out of all of those cases that had a persistent motor deficit. And in this one patient, so this is interesting, this one patient, we lost our direct cortical motors during the procedure completely. And we also lost our transcranial motors. One of the things that we do from a troubleshooting standpoint when we lose motor potentials, we turn up our stimulation intensity to see if we can get a response back. Because a lot of things are happening that might not be structural damage to the primary motor cortex or the spinal tracts. If there's any kind of brain sag, we might lose potentials. If there's any shift in the electrode, direct cortical electrode, we might lose potentials. So we do have troubleshooting algorithms that we follow, and we couldn't get the direct cortical to come back at all. But as we turned up the stimulation intensity from the transcranial motor potentials did come back. So the stimulation through the scalp came back, and we didn't get that coactivation or that ipsilateral response at all. So this patient ended up waking up with a persistent motor deficit, with transcranials coming back and direct corticals not coming back at all. So in the immediate post-op phase, transcranial motor potentials have a low sensitivity and a high specificity, so 17.5% and 100% specificity. Now, direct cortical motors, slightly better sensitivity at 25%, but that wasn't statistically significant, and the same specificity at 100% detecting immediate deficits. At discharge, both transcranial motors and direct cortical motors improved, 43.8% and 50% respectively. And then at 3 to 6 months, we had one patient with that permanent deficit, which I discussed, and all other patients with intact transcranial motors and or direct cortical motors maintain their preoperative motor status at 3 to 6 months in the absence of tumor progression. Now, the specificity for direct cortical motors and transcranial motors was 100% at 3 to 6 months. So we come back to the question, can MEPs or motor potentials prognosticate short and long-term motor function after brain tumor surgery? And the answer is yes. However, motor potentials, and both direct cortical and transcranial, show better sensitivity in long-term outcomes than short-term. And this is important because when you read the literature, a lot of literature says that motors can't detect certain neurological deficits, immediate deficits in brain tumor surgery. And I think a lot of that has to do with the potential for supplementary motor area syndrome or SMA syndrome. That in the literature, it says the motors can't detect SMA syndrome. When the patient wakes up with SMA syndrome, they're hemiplegic on one side, they have speech issues potentially, and the motors don't change. So the literature says that the motors cannot detect it, but I think we're asking the wrong question. I think the question is, can the motors tell you, will this patient get better? If it's a true SMA or it's a non-structural damage to the primary motor cortex. And I think that answer is definitely, based on what we see, you know, true. If the MEPs are intact, the chance of a true structural damage to the primary motor structures is extremely low, and the surgeon can have confidence that the patient will get better. It's most likely something else, whether it's SMA syndrome or postoperative swelling or irritation of the motor cortex. It's not a structural damage to the motor cortex. If the motor potentials are stable at the end of the procedure, specifically direct cortical and transcranial together, it's just more information. And that's pretty much, I think that's what we have to look at is are we, asking the right question? And, over long term, we're seeing that if the transcranials are stable, long term, the patient's going to be okay. So I want to thank you guys for inviting me today. And this is my son doing an EEG on his brother.
Justin, thanks so much. It's super interesting. I mean, I've grown to utilize this a lot in my practice, and part of it is just because of what gets, comes my way, and part of it's because that it gives me an extra sense of confidence when I'm doing these cases for prognostication for patients. When I tell that people, if the monitoring is perfect when you wake up, you may have a deficit postoperatively for some period of time, but it will improve. And I'll be able to tell you that, confidently based on this. And I think this is actually probably the largest series of this in brain tumors, definitely in brain tumors. What I find super interesting is that period of time from immediately post-op to discharge, where, there's still a persistent deficit of some sort. And I'm just curious, and maybe you can lay it out. I think you mentioned some of these things, but what are some of the things that you think can cause that deficit that doesn't come back before discharge? It doesn't come back after just a day.
Well, I mean, we touched upon SMA syndrome, right? Supplementary motor area syndrome. I think that's the big, player here, right? If you're working in the prefrontal area and you're manipulating that area, these patients wake up weak or out completely, and it takes time. And I think what's nice about the motor evoked potential is that if it is stable, it's SMA. Because I think from a surgeon standpoint, right? And I'm not a surgeon, so I think from your standpoint, if you're not 100% sure, it's definitely more anxiety driven, right? If you don't know, right? Because you're like, well, is it SMA? Is it not SMA? I think what we're saying here is it's SMA and the patient's going to get better. Other things can also happen. I mean, you can have vasospasms that are occurring. You can have just manipulation of swelling in the brain, manipulation of the motor cortex or the cortical spinal tracts, where they're just irritated, but they're not damaged. So, the patient's intact, functionally, they get better, over time.
Yeah. And I think it's important to note too that, we did exclude patients who progressed in a peri-eloquent region, right? And so this is not necessarily, the same for, let's say, a very aggressive grade 4, glioblastoma right adjacent to the motor strip that's going to progress into the cortical spinal tract. These are patients that have either not progressed or the lesion is, remote enough or gone in a different direction, where you can use the monitoring to kind of give you that confidence that things will get better by that 3-month time period. The other thing I wanted to bring up was that category 2, I think it was the patients who lose some monitoring and it comes back. This is something that you and I know discussed at length. It's very hard to kind of categorize this because we don't know if it's a true positive that was reversed by an intervention or if it's, a lead misplacement or something like that. And that was the struggle I know that we had, if you want to comment on that a little bit.
And that's always the thing, right? And part of these retrospective analyses, right, where we're never going to allow the patient to wake up with a deficit, right, if we can help it. So we're never going to let it go away and not tell you or not try to reverse it. And I think there's a lot of things that happen. I think from our standpoint, we try to correlate it. What are you doing? Where are you? What's, what structures are potentially at risk? Are there vessels that we're worried about that potentially are a problem? So I think that's really, you know, the the issue at hand there, right?
Well, I mean, I certainly see that, in some of these reversible changes that occur. I mean, obviously there are opportunities where you are making intraoperative changes, either in blood pressure, retraction, the placement of the lead that somehow those neuromonitoring signal changes that look so disconcerting become improved, where I think you can't help but think that these are related to the degree of retraction or the degree of perfusion in the adjacent tissue that you're monitoring. We had first of all, my hat's off. You guys did a great study. This is, I think, the largest monitoring study for brain tumors. Very well done, contemporary. Really solidifying, I think, what's contemporary practice, arguably what may be best practice, not everywhere, but certainly in areas that have these capabilities. We had a great talk, I think it was a week or two ago, Randy will remember, about TMS and functional connectomes. So that I'm intrigued. I mean, these patients who do have a deficit in the short term and then after discharge but improve, or oftentimes, I think you're right, these patients with existing functional connectivity that can be enhanced through a combination of rehabilitation and maybe even targeted directed TMS. And there was a great talk a week or two ago by another colleague and related to a publication. But I think you all are on that sort of spectrum of how we can look at detecting problems, adjusting for problems, and facilitating intraoperative interventions, and then post in the immediate postoperative and intermediate postoperative phases. How do we functionally restore these patients who may have some degree of lingering deficit, hopefully not a permanent one? Unfortunately, there were not that many. The permanency of these changes was few and far between, but I suspect that that's again in keeping with the experience of you and your team. So
yeah, absolutely. I think you kind of hit the nail on the head, and those are things that obviously we're very interested in as well moving forward. There's a lot of data here too that we haven't even really explored, such as when we do have these positive changes. What constitutes a positive change, right? We set it at 70% drop in magnitude, but can we look at more specifically at what a real drop in amplitude means?
Right, and
oh, go ahead.
Just to kind of follow up on Dr. Vigo's point, we kind of subjectively look at amplitude changes, and we try not to be too sensitive with it, right? Because then you have having too many false positives. But looking towards the future, can machine learning help us? Can we get the area under the curve? Can we figure out, is it an anesthetic change versus a true physiologic change versus a motor, a structural change versus technical, and really know within seconds, how that is. And I think maybe that's AI, maybe that's machine learning. I know there are some groups working with some machine learning programs in the country, looking at area under the curve and basically looking at whether or not changes are what they consider real versus anesthesia related changes, because anesthesia does affect motor potentials, and it can. I mean, we're fortunate to be in a good position and with a good anesthesia team, and it's not usually something that we have to worry about, but every patient's different, they metabolize differently, and these are things that maybe for the future we're going to start looking towards.
Well, I mean, you certainly raise an incredible point there, that this is really, it requires a great team effort, and anesthesia needs to be completely on board with what the surgical team and the neuromonitoring team are trying to do. I wonder if I may ask another question, which is, when in patients, Randy or Dr. Silverstein, they come in with a pretty profound deficit. Maybe they've got, 3 out of 5 or 2 out of 5 power. How useful and how routinely are you doing either a direct cortical or transcranial monitoring in those patients? And if you are using it routinely, are you witnessing some changes as you maybe at times for the better in some of these patients in an intraoperative fashion? And is that can that be used as a predictor of clinical improvement over what their baseline may be?
I'll tell you from my experience, it's not often that the responses get better. Typically, because it's usually a chronic issue they have, right? So if there's anything that's pushing on the motor structures, that's happening over time, and that doesn't get better right away. We have had it. I've every now and again said to Randy, "Hey, the responses got better if you pluck that tumor out."
I was laughing internally because I make him say it.
But it's not often. But again, that's where maybe this AI and the machine learning come into play, because maybe we're just looking at it in too big a fashion. Maybe it's more micro than we realize, and we
Right.
see little increments, in that sense. But when you talk about patients coming in with pre-existing deficits, I mean, we do motors on every case that we can, and we try to do direct corticals in every case that we can, because again, I think that they're just going to be more superficial, more specific, and we use the transcranials as that pilot. So if they're coming in with a 3 out of 5, typically 3 out of 5, we're going to get, with the right anesthetic regimen, you're going to get motors from a patient.
Right.
If they're 1 out of 5, you may not get a patient. And then you also have to superimpose whatever underlying comorbidities they might have besides the weakness. Are they diabetic? Do they have a diabetic neuropathy? There are other things that are affecting the nervous system. And then on top of that, add anesthesia. So if the anesthetic regimen is not appropriate for the monitoring, or just that patient doesn't metabolize anesthesia the way a healthier patient would, then it's gonna be hard to get motors. So we do use the motors as a pilot, the transcranial motors, and if we don't get transcranial motors, we do place a strip electrode and see if we can get it. And there are times we don't get it, especially when you start getting that 0 out of 5, 1 out of 5 patients. 2 out of 5, 3 out of 5, we typically will get motors. They might not be the best, they might be weak, but if we have something to go by, we know there's continuity. Kind of go from there.
Right, right. Well, that's been my experience too. Once you get down to that 1 out of 5, there's not a whole lot that you're going to be able to really hang your hat on from the monitoring standpoint. But fabulous study. And Randy indicated you've just maybe this is the tip of the iceberg, so more to come, I hope.
Absolutely, and that I was just going to say that what we're just discussing is also probably pathology dependent. And, we've got a great number of cases here, and we've got a variety of pathologies. And so I think diving into the individual pathologies as we increase the numbers will allow us more information about that too. And using the connectomics that you were mentioning also, are the tracks being displaced? Are they being, interrupted, digested by the tumor? This is all information that will come out. And I think, terrific work, Justin. I'm really proud of this paper. I think it's a great paper. And Jason, thanks for having us both on.
It's a pleasure. And as always, I hope we'll see more from your group. I'm confident that if that's the case, we'll have you back on. And Randy, thanks for organizing this again. And we just want to add one more note. You've got a great series coming up. I mean, this has been a phenomenal start to 2023, and I hope all our participants, both in real time and on demand, are enjoying the start of 2023 Tumor Talk.
Yeah, we got a busy couple months ahead of us. Anyway, thanks everyone so much for tuning in. Justin, thanks for coming along. We'll see you all next week. Take care.
Thank you for the invite.